Hello and welcome to today's webinar. My name is Trevor. I'm the Communications Manager for the Canadian Cancer Survivor Network. Thank you very much for joining our webinar today, which continues our 2025 Winter Series. If you're new to our webinar, a little background on our group. CCSN works to connect patients, survivors, and other stakeholder groups with decision makers and the wider community to engage in discussion and to act on evidence-based best practices to alleviate the medical, emotional, financial, and social costs of cancer. For more information, visit survivornet.ca. Now, this webinar is being recorded and will be available on YouTube, and a link will be provided with the email you registered with, along with a link to the slides you see with this presentation. We will have a quick Q&A session at the end, but if you would like, please put your questions at the GoToWebinar chat function. It should be on your toolbar on the right of the screen if you're signed in on PC. And now to introduce our presenter. Dr. Christopher O Brien is a leader in the nuclear medicine community. He was chair of the Ontario Medical Association section on nuclear medicine for over 10 years. He is also president of the Canadian Association of Nuclear Medicine, as well as the Ontario Association of Nuclear Medicine. In addition, he was a board member of the Royal College of Physicians and Surgeons for 8 years. Currently, Dr. O'Brien is the medical director and chief of service for nuclear medicine at Brantford General Hospital and Pembroke Regional Hospital, as well as coordinating and leading the division of nuclear medicine at Stratford General Hospital. His focus has been on ensuring a high-quality nuclear medicine program for the patients in the communities he serves for over 30 years. And so without any further ado, I'd like to hand it on over to Dr. O'Brien for his talk, PET Scans 101, a guide for patients and families.
Okay, good afternoon, everybody. Thank you for taking time to join this session. Hopefully it'll be informative for you. I've tried to keep a nice overview of what nuclear medicine is and the role that PET plays in the help and diagnosis of various types of diseases. We're going to focus on cancer, and as well as talk a little bit about therapy. So next slide, please. And I don't have any disclosures, so there's no bias in what I'm saying. So these are the objectives of today's lecture. I want to do a brief overview of nuclear medicine because I think that's important to understand PET, so you get a basic understanding of where we're coming from. Then I want to look at the role of nuclear medicine in diagnosis using different types of equipment and medical isotopes, because that'll help get a better understanding of how PET helps in cancer management. And then lead into the concept of therapy, because with PET, you also have the ability to get therapy done as well. So they're kind of all linked in together. So we can go to the next slide, please. So I want to do a little brief history of where we are coming from in nuclear medicine. We are a Royal College specialty, and it takes about 5 years after medical school at a minimum to get trained as a nuclear medicine specialist in Canada. Many of our individuals do a combined radiology and nuclear medicine fellowship program, because that helps to get overlap between the two specialties. Many of our specialists will actually go on and do another fellowship in the sense of either in therapy, pediatrics, cardiology, or PET, positron emission tomography. Now, PET scanning is called positron emission tomography, and we'll discuss that a little bit later on. Nuclear medicine is different. Many of us have had X-rays, CT scans, MR, and those techniques look at the structure and what the organs and cells and tissues look like. What nuclear medicine does is assess the function of those organs, cells, and tissues, and we use what's called medical compounds to assess cellular and organ function, and we don't look at structure as such, but we do have the ability to do that with some of our more modern pieces of equipment. So next slide, please. And so the concept of a compound, why is that important? Well, each of our organs is made up of different cells. If you look at the bones, they have two types of cells called osteoclast and osteoblast. You look at the liver, you have two different types of cells. You can look at a kidney in different ways. So it's important to have a compound or a drug, if you will, that will go to those specific cells and tissues of the organ. So if you're looking at a bone scan, which some of you may have had already in your workup, that uses a compound which goes to the osteoblast type of cell within the bone. There's two types of cells, osteoclast and osteoblast. An osteoblast is the repair mechanism for bone injury. So we use a drug that is specific to the osteoblasts. And what we then do is put a radioactive tracer onto that drug, which allows us to see where the drug is going and to get a better understanding. And that gives us the concept or the approach of developing what's called a medical isotope. And some of you may have heard that in the past. And what nuclear medicine is all about is, what is the medical isotope doing? Next slide, please. And so how do you get the medical isotope into the body? Well, there's multiple ways to do that depending on what we are looking at. The vast majority is through an intravenous injection into the vein. We can use a vein anywhere in the body. Usually it's in the arm, but if necessary, we can use the hands and feet as well, because all we need is a vein to get that medical isotope into you. Depending on the type of study, you may breathe in the radioactive isotope as well, or you may swallow it, depending on what we're doing. So if you're looking at how your stomach is working, you will swallow the radioactive isotope, and then we can follow that path through the stomach into small bowel and eventually colon. If we're looking at an issue of how are your lungs functioning, you'll breathe it in and allow us to see how the airflow is going into the lungs and where it's going. And so there's multiple ways to get the medical isotope into you. Now, the nice thing about medical isotopes is that there's really no serious side effects or reactions. It's completely different from an X-ray dye that you may have an allergic reaction to. So some of you may have had CT scans or MRI scans with contrast and enhancement, and you're always told that there's a risk of an allergic reaction when you have that. With nuclear medicine, there is no risk of an allergic reaction from this. There have been a few cases, I think about 7 instances and over 100,000 injections of people having a little rash at the site of the injection. So it's very safe, very easy. And because of that, we can use a medical isotope in almost any age group. So what happens next? You've received the injection. Let's say we're going to focus on injections for our discussion here today. So what happens then? Well, we need the ability to look at where that injection has gone to. And so in nuclear medicine, we use a specialized camera, either what's called a SPECT camera, which is single photon emission computed tomography. Big name, hence we use the SPECT acronym here. Or we can use a PET scan, which is positron emission tomography. And what these do, these are like big Geiger counters, and they look exactly like a CT scan or an MR. So there's no real difference in the structure. When you walk into the room, you'll see a similar type of machinery. And what this does, these are passive pieces of equipment which actually absorbs the radiation coming from you, because you're the radioactive source as a result of the injection, breathing, or swallowing. And if you've ever had a chest x-ray or some type of x-ray, you know everybody leaves the room except you, because x-rays are a different type of energy. What we're using in nuclear medicine is a different type of radioactive entity called a gamma ray. And this is a different type of radiation as compared to X-ray. And as such, you notice nobody leaves the room. You may have the technologist sitting with you. Your family does not have to leave. Your family can sit next to you, etc., because it's a different type of radiation that works differently. And so it's very important to note that the medical isotope is the most important aspect of the nuclear medicine procedure. The equipment is very important in mapping it. So there's a big difference. So a lot of my discussion will be talking about the medical isotopes. Okay, we can have the next slide, please. Now, why nuclear medicine as compared to MR, CT, etc.? To start off, they're all important. They all have a significant impact on the workup of various types of diseases, cancer in particular. But what are the advantages of a nuclear medicine study, let's say over a CT scan or an MR? Because we're looking at function, we can detect disease when there's only about a 10% change in function at the cell or tissue level. So whereas if you're going for an X-ray, standard X-ray, you may need a 30% change in what's called the appearance or density before that abnormality can be detected. So if some of you have you've been in a sports activity, you're having pain in either the foot or the leg or perhaps the hands, you've gone for an X-ray and it's normal and you're told there is no fracture, but the pain persists over a couple of weeks. So you may come and do a bone scan, because we would be able to detect only a 10% change in function, and therefore we can see the fracture before it becomes apparent on X-ray. So it's that type of approach because we're looking at function, and as such we can detect disease at an earlier stage as compared to more of an anatomic or structural assessment. Okay, and that's we're very good at detecting disease at a very early stage, which can help you make a decision with your doctor on what's the appropriate management you would like to undergo. Next slide, please. So medical isotopes are used in both the assessment of benign and cancerous disease. Benign means just like sports injuries, infections, lumps and bumps, etc. And the medical isotope can be used in all ages because there's low risk, there's no side effects, there's really no risk of death associated with a medical isotope. So we do studies on newborns, which are like 3 to 5 days old, especially if there's problems with their liver function. And we go right up to any adult age. Usually, you know, I've scanned people who are 102 years old. So anybody can come and have a nuclear medicine study. We won't do any studies on pregnant individuals because we don't want to expose the fetus to radiation. That being said, we do lung scanning for blood clots during pregnancy, and this is the safest approach to detect a blood clot in an individual who is pregnant. So we do studies on pregnant individuals, but on a specific type of disease process. Blood clots are very important to detect because they can cause a lot of problems. So next slide, please. So what we're looking at here is, you know, the uses of medical isotopes, etc. What do we do with them? Well, we can look at neurology, which is looking at the brain and brain function. One of the uses of this is assessing brain death. So if you have a friend, colleague, or loved one that's in the intensive care unit and there's a concern of, is the brain still functioning? And the patient may have said, I wish to donate some of my organs and tissues. Brain death study is what we can help our intensive care individuals to determine if the brain is still functioning. And if it's not functioning, then that individual is declared dead, even though the heart is still beating, but there's no brain function left. Other aspects would be Alzheimer's disease, which some of your family members may have. We have a role to play in helping the physician get an understanding of whether there's Alzheimer's disease and the degree of involvement. Both using SPECT or PET is able to look at this assessment. We're able to look at Parkinson's disease. Some of your friends may have this, and we're helped to determine the degree of abnormality within the brain leading to Parkinson's disease. And some use is also used in psychiatry, looking at bipolar disorders, mood disorders, depressions, etc. So there are specific indications that we can help in psychiatry as well. Other aspects that we look at is heart disease. We may do this for chest pain assessment. Angina, you're walking along, you're shoveling the snow, which many of us have been doing for the last week. And you start to develop chest pain. And the question is this due to muscle issue? Is this due to breathing issue? Or is this due to heart issue where there's poor blood flow to the heart? So nuclear medicine is very good at assessing chest pain, both using SPECT, the gamma camera we discussed, or PET. Both have the ability to look at this. The other aspect is congestive heart failure, where your legs may start to swell up, you're having shortness of breath, you can't walk upstairs or walk along a flat hallway or road without having to stop. We can do studies that assess whether your heart is functioning. Many people may go for an echocardiogram, which is an ultrasound of the heart, but nuclear medicine can also help out in more complicated cases or as a first-line assessment. Now on chemotherapy, that's the other component we look at. If people on the audience have undergone various cancer therapies, they may have come to nuclear medicine to have what's called a heart function study or a MUGA. And this allows us to assess the effects of chemotherapy on heart function. We can use also echocardiogram of the heart, which is ultrasound of the heart. So the two together can give a very good understanding of any effects that chemotherapy may have on the functioning of your heart. The other component more recently is looking at heart function or an infiltrative disease called cardiac amyloid. And this can affect the heart and resulting in a heart failure type of presentation. And the importance of this now is that there's a therapy for this. So before we were able to do this, but there was never any treatment. Now we do have treatment for this. So we're seeing increasing interest in this type of nuclear medicine procedure, which is very accurate in the detection of amyloid without any need for biopsy of the heart. So that's a very important help we can have there. Next slide, please. Now we're looking other uses, which many of you may have undergone. If you've had various types of cancers, you may have undergone a bone scan. And that's a very simple procedure where you give an injection in the arm with the radioactive medical isotope I discussed previously. And then we wait about 3 hours to allow the substance to be absorbed within the bone structure, and then we take a picture of it. Now, I alluded to the concept of sports injury. You're running, you're playing soccer, track and field, skating, etc. You may have what's called stress fractures. And so the bone scan is very sensitive in picking up that type of injury to the bones. Usually, we need to wait about 2 or 3 days after the injury because we have to allow the cells to start functioning to do the repair job. And those are the osteoblasts that I commented on earlier on. But the sensitivity is very high in the sense we're pushing by about 4 to 5 days after the injury. Our ability to detect the fracture is pushing over 95%. So the x-ray is still normal, the bone scan is abnormal, then you can go on and get the appropriate treatment. Some of the things we look at too for back pain is there are joints in the back where the vertebral bodies attach to each other called facets. And these may become inflamed. And if your doctor wants to identify which of the facets are involved in the disease process, we can do a bone scan. And many of our gamma cameras also have a CT scan attached to it. So the SPECT may have a CT scan. The PET scan may have a CT scan attached as well. And this allows us to accurately localize areas of disease, excuse me, and allow the physician to know which facets he or she has to target to put injection in to reduce pain. Some of you may have had joint, knee, and hip replacements that may have been acting up, and so the bone scan is very helpful in assessing whether there's loosening, fracture, or perhaps infection associated with those artificial joints. We can supplement the bone scan by using what's called a white blood cell scan, which some of you may have undergone to get a more accurate understanding of whether there's actually infection around the joint or not. So we may do a bone scan and then follow that with a white blood cell bone marrow. That helps your orthopedic surgeon to determine what happens next. And of course, cancer spread to bone, which is again, the bone scan that you may have had if you've had lung cancer, prostate cancer, breast cancer, colon cancer, or renal cancer, to name some of the few types of cancers that we can assess and help your oncologist to determine if there has been spread of cancer to the bone. That can be done both through SPECT and both through PET, so the two type of gamma cameras. Other organs we look at are liver, gallbladder, and kidney, again, using specific type of medical isotopes that target the specific cells in each of these organs. Thyroid disease, we can make a diagnosis of overactive gland or help in the diagnosis of cancer of the thyroid. And we can also use medical isotopes to treat the thyroid as well. And we'll discuss that a bit later on. Parathyroid are small little glands adjacent to the thyroid, which can cause problems with calcium metabolism. And so we're able to help your endocrinologist or surgeon to determine whether there's active disease within the parathyroid glands, which will aid the surgeon to determine where that gland is and to help in the resection of the gland through surgery, because these do have to come out if you find them. They're not cancerous, but they can cause a lot of problems. So if you have that diagnosis, you want to get it out. Excuse me. Some of you may have rheumatoid arthritis or other type of disease process resulting in a dry mouth, and we have a test that can help assess whether that is the cause or not. Very simple test. We give an injection, we take some pictures, then the joy of joy, we give you a lemon to suck on. And that allows us to see whether the gland is functioning or not, and it's very accurate in helping your rheumatologist address the issue of dry mouth. We talked about lung scanning a bit before, looking at blood clots. The other aspect we use a lung scan for is preoperative assessment in case, let's say you have a lung cancer and there's thinking about having the lung resected. Sometimes the individual will be sent to have a preoperative lung scan to determine how much function is associated in the other lung. So that's very helpful in your surgeon and planning a management and the best approach to address your cancer so you're not left worse off after surgery than before surgery. So let's go on to the next slide, please. Now, SPECT scanning, as I mentioned, that's found in almost every nuclear medicine department around the world. It's the first line assessment for multiple disease processes, and it uses medical isotopes, which are specific to the type of cell that may be involved, so as we discussed. Now, it doesn't look at the direct cancer cell, it looks at the indirect effects of cancer being spread to various organs. And it's very useful in patient management. This is kind of the first line approach and management. You may have had breast cancer, you'll come for a bone scan. You may have had prostate cancer, you will go for a bone scan as well. Highly sensitive, you in the ability to find whether that cancer has spread to the bone, and by putting a CT scan attached to that, you can actually localize the lesion more accurately, and therefore you have very high ability to find the tumor as well as localizing it accurately, and that helps your physician manage your disease more effectively and increases the accuracy. Next slide, please. So areas we've looked at are lung cancer, thyroid. Carcinoid is a type of cancer which affects, it's called a neuroendocrine cancer. And there are some people may be on this call who've been diagnosed with carcinoid. And we do have specific medical isotopes that help in the detection of this. Renal cancer, colon cancer, as we discussed before, using various types of isotopes as well. Next slide, please. Now, you'll notice I've not put any pictures here. I've done that intentionally. I mean, pictures are nice, but when you look at a PET scan, they all look the same. What's important is the medical isotope being used. So the nuclear medicine physician will review the PET scan images, but by knowing if I'm using one type of isotope versus another type of medical isotope versus another type of medical isotope, I'm able to detect the various types of cancers. But if you just took a quick glance at it, they all look the same, basically. So when we're doing PET scanning, and so this is what the topic of what we're going to look at. So PET scan is mentioned as positron emission tomography. Looks exactly the same as a CT and MR, and looks like a modern, and the modern SPECT cameras look the same as well. So basically you go into a tube, very similar to CT. It is not as small as a tube in MRI, so most people can get through the study. There are some people who are claustrophobic and really cannot get through without having some help, either a mild sedative like Ativan just to help calm the individual down. But most people can get through either the SPECT or the PET scanning. Now, PET scanning is different from SPECT. As I mentioned, SPECT scanning looks at the effect of the tumor or the cancer cells on the tissue. What PET does actually looks at the tumor cells themselves. And so we have a wide range of medical isotopes that are specific for different types of cancers, and we'll discuss that a bit later on. PET scanning is a very good piece of equipment because it really gets to detect lesions that are small in size. A SPECT scan, you can go 8 to 9 millimeters, maybe a centimeter in that range. So you're around a centimeter in size. PET scanning can get down to about 2 millimeter resolution, so it's very helpful in detecting a disease when the organs or cells still look normal on CT or MR. The nice thing about a PET scan is that you can look at everything in one fell swoop, if you will. So you're able to look at the spread of cancer, you're able to assess whether there's any lymph node involvement, and this is important in what's called staging. And again, if some of you have gone through various cancers, you know staging is very important because that will impact the type of treatment you will get. The PET scan can look at soft tissue involvement and look at bone involvement. So one fell swoop, one study will give you a lot of information about, is the cancer still just localized to one area? Is it spread to the local lymph nodes, or has it spread to other organs and or bone? So again, it's very important that this type of information is available to you and your doctor, because that allows everybody to make informed decisions on what the best treatment for you is going to be as we try to move more and more towards personalized medicine. What is the best treatment for you rather than what is the best treatment for everybody who has a lung cancer? Because each of the cancers may be a little different. So we really want to help you and your oncologist to determine what your type of cancer is and what is the best treatment for your cancer. Okay, so we can go to the next slide, please. And so what we've done here, little bit, cancer cells are hungry for sugar because they're very active. They really need a lot of metabolic demand. And so the first approach, and it's still a very powerful tool today, considering PET scanning has been going on for about 20 years now in various types of research, etc., and actually even longer than that. What was developed to a compound was a sugar analog called fluorodeoxyglucose, another long name, hence FDG. And F-fluorine is a radioactive agent we put onto the sugar analog, deoxyglucose, the DG there. And what this does, the compound DG is incorporated into the cell and goes down the same pathway of metabolism as sugar would, except it cannot get beyond a specific point in the pathway because of the deoxy nature of the glucose, the D component in there, and it becomes trapped in the cell. And therefore, we're using the radioactive agent, the fluorine, we can now map out which of the cells are abnormal. And we do this through a couple of ways. One is looking at it. There's a reason we go through 5 years of training or 6 years of training here, because we really have to have an understanding of what disease processes do to the altered distribution of the medical isotope. We also have the ability to do computer assessment with this, a quantitative evaluation, because not all abnormal uptake of this medical isotope means you have cancer. And we use a number called SUV, specific uptake value. And what this does, it allows us to separate benign low-level disease or non-cancerous disease from cancerous. Cancer cells, as mentioned, have a higher need for glucose, so they will pick up the FDG more avidly and will have a higher SUV value. And we can use that to determine whether this is something I have to be really worried about now. Let's say if your SUV value is 8 as compared to an SUV value of 1 or 2. I'm dealing with 2 different disease processes here, and I don't really have to worry about a significant cancer burden if my SUV ratios are very low. So we look at it visually and we look at it quantitatively, and that's an important component in helping you and your physician to determine what next stages do you have to do, because other things can cause increased metabolic activity, such as infection, inflammation, as compared to cancer, which is even a higher level. So by knowing the SUV, we were able to detect whether that is malignant or non-malignant. So that's very important and helpful. And staging is improved over routine workup. So what this does, in the sense that since we are able to detect disease at an earlier level when the organs and lymph nodes may appear to be normal, we can actually help to determine what stage you are at. Where is the cancer? Is the cancer just localized to a specific area? And as mentioned, has it gone to the lymph nodes? Has it gone to other organs or bone? And the importance of a PET scan is not making, let's say if you have 7 lesions detected, if you have 9 or 10 lesions, it really doesn't change your patient management. The importance and power of a PET scan is determining whether you have 0 lesions or 1 lesion. Because if you have 1 metastatic spread somewhere in the body, your stage is now totally different and your treatment will be different. And so using a PET scan improves the staging over routine CT or MR because of the ability to detect disease at an earlier stage when the organ and cell may still look normal. Can we go to the next slide, please? And so we started off with fluorodeoxyglucose, the sugar analog, which was, again, this was very similar to our bone scanning agent in the SPECT nuclear medicine department. It wasn't specific to the tumor. It was it was looking at what are the tumor cells doing in general. FDG was a very powerful tool in detecting what stage the cancer is, where is it, etc. But again, it was more of an indirect assessment of the various cancers that we're looking at. And so the next level of discussing of the medical isotopes was, how can I find a medical isotope which is specific to the specific type of cancer that I'm looking at? And that increases the accuracy of the procedure, because if you're just looking generalized, as I mentioned, glucose, you can have infection, inflammation, and tumor, which may show various types of sugar uptake. If you're looking at prostate cancer, there's an agent called PMSA, prostate membrane specific antigen. And what this is, it's like a lock and key type of approach. Sitting on the cell is the lock. And what our medical isotope is the key that goes into the lock. And what this enables us to do then is to develop a type of medical isotope which is specific to a specific type of cancer. If you've had prostate cancer, you know you've been screened for PSA levels, prostate specific antigen levels. You go for the blood test, you'll find your PSA is 8, 10, 20, 50, 100, or you may find your PSA levels is 1 or 2. And again, depending where that PSA level is, you have the increased concern for, do you have prostate cancer? And you may go for an MRI scan to help stage or get a better understanding of the prostate. And then you may ultimately go for a biopsy to confirm the tissue that there is cancer. And then you may go for what's called a nuclear medicine PET PMSA scan. And what this enables the doctors to do, your oncologists and surgeons, is to get a better understanding of the involvement of your body with the tumor. Another type of cancer, we talked about carcinoid in the past. Nuclear medicine SPECT scanning has one type of medical isotope. The PET scanner has a different type of medical isotope called dotatate. And what this does is enables the surgeon to get a better understanding, once again, of where that carcinoid cancer is. And the PET scan using dotatate is much more accurate than the SPECT scan using octreotide, which is the agent that we use in nuclear medicine. So we're slowly seeing the process of historically where we were using octreotide scans, because that was the only isotope available, medical isotope. So we were using that, very good at detecting. Carcinoid with dotatate is much better. So we're seeing that drift now going towards PET scan as being the first line assessment of a carcinoid type of tumor. Breast cancer is coming up down the pipeline too. It hasn't had the success yet as compared to prostate cancer and carcinoid. there is an agent called estradiol, which is estrogen. If you've had breast cancer, you want to know, is your estrogen receptor, progesterone receptor positive, negative, triple negative, etc. So what our breast cancer PET scanning does is help to sort that out as well. Other techniques such as mammogram, MRI, ultrasound, etc., are still very powerful tools and are still the first line assessment for breast cancer assessment. But using an FDG or estradiol, you may be able to see if some of your lymph nodes are involved and get a better understanding. So it's not yet ready for prime time, but it's coming down the pipeline. Another medical isotope that is very exciting at this point, it's not yet approved yet for clinical use, is called FAPI. And what this is, it's a type of, again, lock and key type of approach, looking at the receptors on the cell surface. But this is also applicable for multiple types of cancers that we do not yet have specific medical isotopes for. And so you need a tissue diagnosis first, and then you can do a FAPI scan to determine where it is. This is very interesting, and this actually, one of these scans won the award a couple of years ago at an international conference because of the impact it had on tumor detection. So this is something down the pipeline. We may see it more in about 5 years or so, but it's very exciting, and you'll see why as we go along into the into the talk. Next slide, please. Now, the one thing about PET scanning is it's one of the most researched type of diagnostic procedures ever. It has gone through more rigorous, large-scale trials and research before any government will fund it. So, and this is around the world. Every country has done this type of approach because they don't want to fund something and subject an individual to a type of procedure which is not going to do anything. And so research has, each of the indications that we have in Ontario or in Canada now have been significantly researched, and the indications that are funded are the indications that have shown to have significant clinical benefit to patient management. And so when you do a PET scan, it's the type of research that has been done. It surpasses anything that CT or MR has had to undergo in the sense of broad, large-scale, multinational, multi-center clinical trials. So when you're going to have a PET scan, you should have a great deal of confidence that this scan is an important scan and it's not a waste of your time and will have a potential benefit in your management. Okay, so next slide. Now, why is this important? The one thing, whether you're going back to the late 1990s when some of the initial research was done, and the research was important because many of the studies were just small studies, maybe 15, 20 people in it around the world. And that wasn't enough to really make significant decisions on. So what the governments did around the world says, we need large clinical trials. We need hundreds of people enrolled in these trials. And we want to see what happens with how does a PET scan impact the patient management. And the interesting thing is that even the small trials in the 1990s, as compared to the large multi-center trials that are going on in 2021 now, 2025, is that they basically all came to the same conclusion. And the reason that is that the PET scanning using specific medical isotopes has a significant impact. And so you're able to detect it in small research volumes and in larger research volumes as well. So again, it was very important to document that these are consistent, reproducible findings, that patient care is being changed as a result of the PET scan. So what is seen is approximately, I mean, sometimes it's 25%, sometimes it's 35%, but in general, it is around 30% of patients who have undergone CT, MR, then they go through a PET scan. 30% of these patients will have a different stage than was suggested either on CT or MR, and those individuals will then have their management changed accordingly. So if you're going to go down one route based on your CT MR findings, your PET scan will make you go down another route with the aim of giving you more effective treatment at an earlier stage of disease. And so putting it together, like if 100 patients go for a PET scan and they've had a routine workup, 30 of those patients will have their treatment changed to more effective therapy. And the aim is to improve survivability. And the ultimate aim is to cure the cancer. And if you can't cure the cancer, to try and get the best therapy to keep it under control. And again, 30 patients out of 100, that's a big number that'll have more effective treatment, if you will. So next slide, please. And initially, PET scanning was used, okay, nothing's working, maybe we should do a PET scan to see what is actually happening. And so the PET scanning was after everything else was done, maybe we should do a PET scan. Because of the impact that's been demonstrated through large-scale clinical trials and that 30% change in patient management, PET scanning is now becoming more and more a first-line evaluation. And as mentioned, the PET scan will either have a high-end CT scan attached to it, or some of the newer centers will have an MRI scan attached to it. There's still some discussion on whether MRI is required for standard oncology workup. It may be good in the pediatric population because it does reduce radiation exposure rather than having a PET scan and a CT scan in your pediatric population. It'll probably play a better role in neurology as well because MRI is superb in the detection of diseases of the brain. So for the foreseeable future, the standard workup will be a PET CT scanner. And with the high-end CT scan associated with these, you can actually do the PET scan, CT, and contrast-enhanced CT. So it could all be done in one sitting. And so at that point, you don't have to make one appointment for the PET scan and one appointment for the CT scan. And that's what's happening now. And what we think will happen in the future, you'll come in and get the whole PET CT scan in one sitting. So all the information is now available to you and your oncologist or surgeon with one visit to the clinic or hospital. And I think that's going to take off a lot of stress from the individual who's being worked up for, is my cancer, how bad is it, where is it, what type of treatment do I need to do? So this allows you to get the information more effectively and quicker so that you can make a decision on what's best for you. Next slide, please. Now, does PET scan increase survivability? Because that's one thing everybody says. Am I going to live longer if I have this procedure done? Well, the reality is no. A diagnostic procedure by itself does not increase survival. And the example I use for this is, let's say you have a cough. You go see your family doctor, and the family doctor listens to you, does an exam, begins to think, I wonder if you have pneumonia. And he or she may then send you for a chest x-ray to determine whether there's his or her suspicion for pneumonia is there. So you have the chest x-ray done. And so the first thing we look at when we're looking at imaging is the quality good. Are you rotated? Did the technologist put you in the right positions, etc.? So that's one thing that could impact the ability to make a diagnosis if the ability to take the picture was not done appropriately. We have well-trained technologists in Canada, and so that's not an issue in the Canadian market, if you will. Other areas, it may be an issue around the world, depending on the training of the technologist. So the next thing, the chest x-ray is done, looks good, etc., and the radiologist looks at it. And some pneumonias are hard to see, some are not. So the next question is, did the radiologist pick it up? Did he or she make the diagnosis that you have pneumonia in the left lung? Sometimes it's missed because it's hard to see. But if it's diagnosed and the radiologist picks it up, then the report is made pneumonia right lung. And again, this is the importance of training. And radiologists go through a 5-year training program, same as a nuclear medicine specialist. we have to be able to have an understanding of what the images are showing us to give the appropriate report to your family doctor. Now, the report's done, the report is sent out, and then the family doctor gets the report and looks at it and then decide, okay, let's put you on antibiotics. Now, the question is, was the appropriate antibiotic given? And if it was, that's good. And sometimes it's not, because the pneumonia is resistant to that. So sometimes there's a trial and error. And the final point is, did you take the antibiotic? So, and if you didn't, then the pneumonia is not going to get better. So as you can see, there's multiple points, pathways, and that can occur in the ability to get a good outcome. So yes, the x-ray was done appropriately. Yes, the diagnosis was made. Yes, the family doctor put you on the antibiotics. You did not take it. So your outcome will be different. So it's the same as with PET scanning, in the sense that we get the diagnosis, we look at it. Then the concept is, what type of therapy is going to be best for you? And so it's not the diagnostic procedure, not the x-ray, not the SPECT, not the PET scan, but do we have the effective treatment for your type of disease, and in this instance, for the type of cancer you have. And this is very important now in staging, because we will change our therapy depending on where and what degree of cancer you have and where it is around your body. And so when you look at this, do we have the therapy? And that's what this is about. So next slide, please. And so staging, this is what this is all about, in the sense that usually when you're doing CT scanning, MR, what you're looking at is the cancer, where is it, how big is it? That's called staging. Is it localized to the lung, as we talked about? Has it gone to the lymph nodes? Has it gone elsewhere? Usually on structural imaging, which is like CT or MR, a lymph node about 1 centimeter or less is considered normal, and 1 centimeter larger, you begin to get worried about this. Could there be cancer in that? So that's where you want to do staging with sentinel lymph node assessment. Now, if some of the members of the audience have had breast cancer, they have probably gone through a lumpectomy, surgical resection of the cancer, and probably have undergone what's called a sentinel lymph node biopsy. If you remember in the old days that you'd have your breast removed and they take off a ton of lymph nodes in your armpit, and you may have nerve damage and or lymphatic damage, so resulting in the arms swelling up. And you may have seen that, or you may have had friends or loved ones who have gone under that and they have large arms now because of the surgery. What we're doing now is using a medical isotope in nuclear medicine, which allows us to map the first draining lymph node. And so that allows the surgeon to take out 1 or 2 nodes, whereas before they may have taken out 10 to 15 nodes. And so there's no impact on arm swelling anymore or nerve damage, because we're able to detect the disease at an earlier stage. The lymph node may look normal, but it may have disease in there. And so what the surgeon is able to do is take out those nodes, send it to the pathologist. The pathologist will say, yes, there's cancer there, you now have a different stage, or no, there's no cancer there, and the disease is localized to the breast. We can do that for melanoma, is another type of cancer where we're assessing where the lymph node drainage is. If you have melanoma as a cancer, this can go anywhere. It can go, if it's in the back, it can go up to the chest, it can go down to the belly, it can go into the groin, it can go across to the other side. So the ability of doing a sentinel lymph node assessment, and some centers do a pre-surgical assessment for melanoma, because the surgeon has to plan where that lymph node is, and the surgical technique will change if the lymph node is detected on the other side of the body rather than on the side of the tumor. So those are the things that help in lymph node assessment, which is very important. Now, from an imaging perspective, do we have a technique that can start looking at small lymph nodes to determine if there's cancer there? And this is where PET is very powerful, because PET can detect the presence of lymph nodes that are smaller than 1 centimeter. As they get down to 0.2 millimeters, or sorry, 2 millimeters or 0.2 centimeters, yeah, it's not as powerful. So you really need a lymph node that's maybe about 0.5 centimeter in size, that you can, that if the medical isotope used in the PET scan is showing activity in that node, you are now very concerned that even though the node looks normal in size, it is actually cancerous. And so that will do a different staging technique as well. And this helps your surgeon to determine whether there is a significant type of tumor or not. If you have prostate cancer, you know, you go through a potential, you may have the PSA levels done, you'll go through a biopsy, an MRI, as we discussed. Some centers now will be doing a PMSA scan to determine more accurate lymph node staging, so that the surgeon will know that if I do a radical prostatectomy where they take the prostate out, that they may not have to do a lymph node assessment because the PMSA scan was negative. And so again, that helps in patient management, helps in staging, helps in what type of therapy will be most effective. So the PET scan power here is the detecting of tumor and tumor burden at a very early stage before it starts to change the shape and structures of the cells. Okay, can we go on to the next slide? Yep. And so survivability is impacted by correct staging and initiating therapy, as we discussed. So let's say if your workup of CT and MR showed the tumor is just in one area, it hasn't gone anywhere. You go for a PET scan using a medical isotope specific for that type of tumor, and oh Lord, you find one lesion which is outside of the tumor, of the primary tumor. So now you have a totally different stage. And so before you've had the PET scan, you would have been told that the tumor has not gone anywhere. We're very good. It's right where it is. We can take it out surgically. We can do some radiation therapy around the local area, and perhaps just in case, we'll do some chemotherapy in case we miss something. Having the PET scan, though, showing that one lesion now makes you concerned that, okay, I am now metastatic disease rather than disease localized. And so what happens if you have one lesion detected? So the power of this is 0 or 1, not 7, 8, or 9 metastatic diseases detected. It's at 0 or 1. So they've detected one lesion suspicious for metastases outside of the tumor bed. So the approach could be, if the SUV is very high, as we talked about, that quantitative assessment, okay, that's cancer, it's now spread. So the concept is, it's surgically resectable. Can the surgeon go in and take out that small area of concern? If it's not surgically correctable, can radiation therapy be used to target that area to kill the cancer cells? So that's one approach that we can do. And but there's other techniques we can use with regards to therapy, and that's getting back to our discussion on medical isotopes. So can we have the next slide, please? So therapy, and so as we discussed in imaging, we are using medical isotopes which are specific to the cancer cell, that lock and key approach, as we discussed. The lock sitting on the cell membrane, and the key is what our medical isotope attaches to detect the disease. Now, medical isotopes can be used to treat both benign and cancerous conditions, and which is interesting. And the same medical isotope can be used either to diagnose or treat just by changing the radioactive agent. Now, is this something new? Well, no. The first use of medical isotopes was actually in 1941, using radioactive iodine-131 to treat an overactive thyroid called hyperthyroidism. This is still the main treatment for hyperthyroidism in 2025. So if you look at it, 60 years later, it's still the best treatment around for an overactive gland. Some people may have undergone, some people in the audience may have actually had treatment for an overactive gland that may have been put on medical treatment first, which didn't work. Then you go for the thyroid scan, and then you do the iodine-131 treatment. It's very effective. About 90% of people will be taken care of with one dose of iodine-131. and then about 10% or less may need a second treatment dose. So this has been around for a long time. Now, iodine-131 can also be used to treat cancer. So you have the concept of using the same medical isotope to detect the disease as well as to treat the disease. And so this is the first time what's called theranostics, and we'll get to that in the next slide, was 1941. So this has been around for a while. So next slide, please. And medical isotopes can be used for, as mentioned, various types of benign and non-cancerous patients, such as you can use the medical isotopes for arthritis. We have different isotopes that can be used for small joints of the finger as compared to the knees, which are larger joints, or the ankles. So we have the ability to use medical isotopes in benign treatments, such as hyperthyroidism, as we just discussed, or inflammatory arthritis as another role in this. And so the trend now is to see if we have a medical isotope that can both diagnose and treat the cancer, and that's called theranostics, and that's what this term is. So if you're ever doing some research, going online, Dr. Google, as everybody calls it, yeah, you'll look up theranostics. And so this is the ability to use a medical isotope to determine where the cancer is, and to use the same medical isotope, but with a different radioactive agent to kill the cancer. And so that's getting now more towards personalized treatment, as we discussed a little bit before. The aim is, do I give you the cocktail, which historically chemotherapies were in the 1970s. They've gotten much, much better, and they're more specific now. So the same concept now is when you're using therapies that are based on your receptors that lock on the cell, so ER positive, prostaglandin positive, etc. And so you have those therapies which are now specific using chemotherapy or immunotherapy as well. But we also have the ability to use medical isotopes. One of the isotopes that we've been using is radium-223, as mentioned here. And this is a very powerful tool for palliation and pain control and management, and to improve overall survivability. Does it cure the cancer? No, but it delays progression, makes life a lot much more comfortable in the later stages of cancer. And it's one of the medical isotopes that can be used in specific patients to make end-of-life care a lot more comfortable for them, and to give them a few more months of life if possible. Next slide, please. So as we talked about theranostics, and this is where we are now in a nuclear medicine approach to cancer management. So we have the ability, the PET scan will diagnose it, will allow us to determine where the cancer is, its stage, and now we can also start to treat the cancer by changing the isotope that's attached to the same compound. And so the detection of the cancer uses what's called a gamma ray, and that's the fluorine that we talked about before on the sugar. And so it uses a gamma ray to make the diagnosis and to give us the image. Now, by changing to a different isotope, which is more destructive, because you don't want to use a destructive agent to make the diagnosis. You want to use a destructive killing agent to go after the cancer and get rid of it. And so by using a different isotope, we are tending more towards what's called particles, a beta particle or an alpha particle. And those are just parts of the atom, as what you're looking at. The beta particle has very destructive capabilities, but it travels a little farther than the alpha particle and may cause damage to surrounding tissues, which may cause some side effects such as reduced blood counts. If individuals in the audience who've undergone various types of therapy for cancers, you have to watch your white blood cell counts because they may drop as a result of therapy. The same thing can occur with the beta particle, but less so than with other agents, because even though the beta particle travels, it's only traveling a couple of millimeters rather than centimeters or inches. The other agent that is becoming very interesting now is called an alpha particle. And again, you can attach that to the medical isotope. And what the alpha particle does, it has a higher killing capability going after those cancer cells. And it doesn't travel very far, so any collateral damage is really reduced. And so now we're seeing the development of various types of therapies in nuclear medicine that can target the cell, same way as you do with your immunotherapy or chemotherapy that you've seen. And we'll be able to go after those cells because we are targeting the cell membrane and receptor with a higher level of radiation that kills the cell locally with minimal damage around the area. So if we can go to the next slide, and I'll give you some examples of what we've just talked about. So with the thyroid, you use iodine to detect, iodine 123, or another agent called technetium that can actually do the same thing. And then you can treat with iodine 131. So the example here is for thyroid disease, make the diagnosis with iodine 123, treat it with iodine 131. And this was the stuff that was going back in 1944 to 41. For prostate cancer, that PMSA medical isotope we talked about, you can use the F, which is the same F as in the sugar, fluorine 18, and you can attach that to a medical isotope called PMSA. You can also use another agent called gallium-68, which can be attached to the same PMSA agent. And so you have different medical isotopes that can be used to detect the cancer in somewhat different ways, but still give the same information. Now, using that same compound, the PMSA, you can change the medical isotope to lutetium-177, and that's will be able to target the cancer cell by using the lock and key approach as we discussed previously, and to kill the cancer. So then you can do a follow-up either SPECT CT scan, as we discussed, or a PET scan to see the effect of treatment. And the aim is to make sure that the treatment is effective. So in other words, some treatments, as some of you may have undergone, 3, 4, 5, 6, 7 cycles of chemotherapy, etc. And the aim now is using PET scanning and for diagnosis and therapy is to help you understand that, gee, after 2 treatments, this has not worked. So before you had to go through 5 or 6 treatments to determine if the therapy is working, the PET scan will enable your oncologist to determine, okay, we have to change our therapy because this is not working. And so you're able to undergo more effective treatment, personalized treatment again at a much earlier stage to get you the best treatment possible so that your overall survivability is increased. Similar with the carcinoid tumor, neuroendocrine tumor, you use dotatate to be able to detect it, and dotatate, but a different isotope, to treat it. And again, you're able to assess the treatment more effectively at an earlier stage with your PET approach. So, next slide, please. Now, the interesting thing now is that the medical isotopes were initially used as a Hail Mary pass. You're gonna, everything else has failed, let's try this. And of course, at that end stage, really no therapy is going to work. So what has been looked at over the last decade or so is, can I start using these therapies at a much earlier time frame in the cycle of treatment that the individual is undergoing for the cancer? And what is being found is that overall survivability and delaying disease progression, in other words, the cancer getting worse, is impacted if you can start the medical isotope therapy earlier on in the treatment process, and usually in combination with an existing type of chemotherapy or immunotherapy. I think the underlying concept here is that there is no magic bullet. However, cancer is very complicated. It's able to mutate, it's able to change its characteristics, it's able to avoid the various treatments we have. You may have been in a remission and then the cancer came back. The cancer has now changed its genetic structure and becomes more aggressive. So unfortunately, there is no magic bullet that I can give you this and you are going to be cured. But if we can go on to the next slide, please. This is where we're talking about combination therapy, and some of you may have undergone your chemo and your immunotherapy, may have undergone immunotherapy and radiation therapy. Some of you will have undergone the immunotherapy and medical isotope therapy. So it all depends on your type of cancer. And the aim of this is to try and kill the cancer cell in different ways. So, and to ensure that the cancer cell cannot adapt to the different types of therapies it's being subjected to. And if you go back to the 1970s, that's where the cocktail was given. Wasn't specific for anything. Side effects were horrid, and effect was not very good. So our medical oncology colleagues and research has moved more and more towards targeted therapy, the same way that nuclear medicine has moved towards targeted therapy. And what's being found now in various research endeavors that are going on now is that the combination of the traditional therapy and when you add the medical isotope therapy, the overall survivability increases over the existing type of standard treatment that you were getting initially. So targeted therapy is more effective than the cocktail, and then combination therapy is even more effective than the targeted therapy. And it's a combined assessment of using traditional with non-traditional therapy that is having a significant impact on tumor outcome, survivability, and life in general. Again, we're getting to the concept of personalized combination targeted therapy. So based on the type of tumors you have, based on the medical imaging, medical isotope imaging that has shown the characteristics of the tumor, you can then start to target that type of tumor more effectively to give you better outcomes. Okay, so next slide. I think we're coming to the end of our discussion here. And so conclusion, mentioned there's no magic bullet here, and I think we are decades away from any type of magic bullet. But medical isotopes do play a significant role in staging what is your cancer burden and treatment, so personalized theranostics. PET scanning will change management in about 30% of individuals, so they'll be moved towards a more effective treatment at a much earlier stage. And if you can initiate effective treatment at an early stage, you will have better outcomes. And how does it do this? Staging, staging, staging. Those are the things, those are the words you have to think about. Staging, staging, staging. I want to detect that solitary metastatic lesion when everything else says you do not have that solitary lesion. I want to detect the lymph node in its small size when it's less than a centimeter and document you have cancer in that lymph node. So you want to do this at an early stage so that your oncologist and your surgeon can be able to give you the most effective therapy at an earlier stage to give you the best chance of survival. So I want to thank you for your attention, and I'm open for questions and discussion.
Excellent. Thank you very much, Doctor. It was a fantastic presentation and quite a bit of an eye-opener to the whole diagnostic side of things, because often we talk a lot about treatment, but whenever it comes to diagnostics and just diagnostics as well, when it comes to just figuring out how the cancer is progressing, that is also very important. I wanted to talk a little bit quickly about your one group, More Pets, or the group that we have the coalition that we are part of with your group, and that's how we got into contact with you. And so I was wondering if you could touch base a little bit about the More Pets coalition.
Yes, well, what we're doing here is we found that the ability to order PET scans in Ontario was difficult. It's getting better now, we must admit, but we also found that physicians may or may not have a good understanding of when to order a PET scan and what is the role of PET scanning in patient management, because this is a relatively newer technique, even though it's been around for about 20 years now. It still is only beginning to get impact into appropriate patient management. So what we wanted to do was increase the awareness of PET scanning in our physician population, and that's what we've been doing in our first stage. But we also wanted to increase the awareness of patients. Patients like to take control of their own bodies, of their own disease mechanism, and the aim is to inform patients that you should ask your doctor, is a PET scan right for me, for my type of cancer? And it's the ability to get that conversation going and to allow the physicians and the patients, the individual with the cancer, to get control of their disease process and take a more active role in discussing. The internet, Dr. Google, as I call it, is very helpful in getting information to patients, but it may not necessarily be applicable to your type of cancer or your type of situation. So the aim of this type of outreach is to allow patients and individuals to know this is a conversation you should have with your doctor to find out, is this the best for me, or is this something we should consider, or am I off in left field and my type of cancer won't be helped with this approach? So that's the aim of this coalition, is to increase awareness and understanding.
Mm-hmm. Now, we've had some questions here about specific types of cancers that PET scans are good for. Specifically, ovarian cancer. Are they a good candidate for PET scans? And are there isotopes being developed to find a target to treat ovarian cancer, which is very famously a very difficult cancer to detect?
It is it's like cancer of the pancreas at the tail. You don't detect it till it's gone everywhere. As compared to pancreas at the head, which is next to the gallbladder, and you get jaundice and you find the cancer early. Ovarian cancer, no, there's no medical isotope for that yet. It'll be interesting to see FAPI, as we talked about the future, because many cancer cells have this type of receptor. And once you make the diagnosis, you would be able to stage it. And the same concept would be, once you've staged it with your diagnostic FAPI, you can change the tracer onto that to start to kill the cell. So we're not there yet. We don't have the appropriate medical isotope, but I think FAPI is going to be very interesting to see if we will in the near future. Ovarian cancer is horrid because really a lot of the detection is done when it's too late or very advanced, and it makes treatment and cure very difficult. Sometimes you're going through an ultrasound of the pelvis for another reason, and they, oh Lord, there's something there, and it's caught early. And that's basically by luck, unfortunately.
Mm-hmm. And same question about PET scans, but this time for uterine cancer.
Same problem. Uterine cancer is still going to be, well, you'll go through your pap smears, you'll go through this for cancer of the cervix, you'll go, if there's different bleeding, you'll go for your ultrasound and your transvaginal ultrasound approach to get better detection, etc. So ultrasound is still going to be the main level of help in staging of a uterine cancer. Nothing yet in for imaging yet. But there's a ton of research. I was talking to an individual about the various types of research and medical isotope development. There are hundreds of medical isotopes that are in the various stages of developing, looking at different cancer types. So again, it's one of those things down in the future. I think, yes, we will have a significant role to play in diagnosis and more likely treatment as well, because once we can make that diagnosis where it is staging, we can kill it with a different isotope. Not there yet, unfortunately.
But that is hopeful that things are in development. I mean, it is quite the way with cancer care, but it's nice to know that things like this are currently in development. There's research going on behind the scenes.
Oh, absolutely. Absolutely. Yeah.
One final question, and this one's a good one. I'm not sure if you have kind of touched base on this and if in the rest of your talk, but it's definitely worth reiterating. The current standard of care in Canada and the US is not to use PSMA PET for staging initial treatment for prostate cancer. You seem to suggest that view is now changing and the PSMA PET might be useful in staging primary treatment. How long before this will become the standard of care in Canada?
Well, part of it is funding. Part of it is the government still wants to have a good understanding of what the impacts that PMSA scanning will have. And there is a criteria that tissue diagnosis is required prior to getting a PMSA PET scan. Because we don't want to use this technology and capabilities just a generalized screening tool. It's like people, let's do a CT scan just for screening to see if I have any lumps or bumps type of thing. PMSA PET scan is more expensive. There's no doubt about that. And you want to use it effectively in the population that it's going to have the most benefit for. So it'll never be a screening study in the sense, do I have prostate cancer? Yes or no? No, that's not what this is used for. It's once you have prostate cancer diagnosed through biopsy, then it is a very reasonable question to ask, should I be having a PMSA scan to help me stage this more effectively? And you're going to see this becoming more and more. Right now, Pluvicto is that's a trade name. Sorry, I shouldn't have done that. It's the lutetium PMSA treatment that is now being funded by the governments across Canada. So before you can do the lutetium PMSA study for therapy, you need to do a PMSA PET scan to determine, one, is the prostate cancer, does it have the type of lock on its cell that the medical isotope treatment will be able to kill? So you're going to need to do both. And so now that lutetium PMSA is being funded, you're going to see a lot more PMSA scans done. Now there's research being done. What is the best PMSA type of agent that should be used for this? And we're coming down to about 2 basic isotopes that will have the best bang for the buck or the best impact on patient management. And we're sorting that out now. But even that being said, a PMSA scan, whatever agent is being used, is much more appropriate after the diagnosis is made as compared to conventional imaging at this point. So you will see that you'll go for your PSA scan, you'll do your MR for your prostate. If your MR staging is high, you'll go for the biopsy, and then you'll do a PMSA scan to determine if lutetium PMSA will be a viable treatment option for you. So that is how I foresee this coming, and very shortly, not decades. We're talking years. We're talking maybe 1-2 years.
That's very encouraging to hear. Thank you for that, for a very positive end to this webinar. Thank you very much, Dr. O'Brien. If anyone would like to know more about more pets, we do have a link to their website on our own website, survivornet.ca. You can find that under the Partners and Coalitions tab. So that one will be, so you can go and see what this coalition is about and what it aims to achieve. And if anyone has any other questions for Dr. O'Brien, you can email myself at communications@survivornet.ca, because that's all the time we have for today. So thank you very much, Dr. O'Brien, for this talk. It's been very eye-opening. So
okay, thank you for attending, everybody. Good luck to you all, and have a good day.
And now this is one of a series of webinars that we are presenting. The next one should be coming up in the next couple of weeks, so check your email if you have any to see when that is coming up. We do use a third-party email service, so please check your inbox and make sure that you are registered for our newsletter and for any of our mailing lists. So make sure that you go to our website, survivornet.ca, to find the link to register. And speaking about our website, if you want to see all of our webinars, you can see them there at survivornet.ca/webinars or on CCSN's YouTube channel. And so with that, I bid everyone a fantastic evening, and I hope to see you on the next one. Bye for now.